This is the Owens Recovery Science Podcast.
Kyle, you doing anything cool this week?
This week?
Yeah. It's a rhetorical question. Rhetorical.
No, I'm doing a podcast with you. That's all I got, man. This is my life. I'm going to Kansas City.
Oh, nice.
Yeah,
nice.
You know the place where they don't have
Midwest.
barbecue. Yeah.
Here's where you ask me, am I doing anything cool this week?
Do we need to restart?
No.
Nah, we don't need to.
No.
Johnny, hey, what are you doing this week?
Oh, not much, man. I'm going to work.
I know where this is going.
Agency, you might have heard of it. It's called NASA.
NASA.
Yeah.
You suck. I didn't even see that coming.
Yeah, me and Ben will
awesome.
be working with NASA this week. So you enjoy Kansas City, man. It's
literally like 20 minutes from where I grew up. Like literally, like right down
I'll
the
go
road.
say hi to your family.
You guys want to drive by the house? Yeah, I'll give you the directions.
Yeah.
Johnson Space Center,
things.
Clear Lake, Texas.
They shoot rockets into asteroids and things like that. So
we just did that, didn't we?
Yeah. So I'm gonna ask them if they want me to analyze some of that, data that they have from that while I'm there.
I'm sure they'll definitely want your input on that. There's no doubt.
I'll take pictures. Maybe I can get you a T-shirt while I'm there. All
yeah,
right,
thanks. Yeah, that'd be great. One of those white ones with the pocket, Yeah.
Oh, you need that pocket protector.
Exactly. Yeah.
So we're gonna roll into our podcast guest here. I don't know if you knew this. I played soccer. Growing up, that was my main sport. It broke my dad's heart because I didn't play. I played football, but I was better at soccer. And so I made a semi-pro team when I was in high school, and my coach was German, and he taught me German.
Okay.
Bad coaches.
Yeah.
Bad coaches.
Okay.
And the only thing he taught me was one word, though. It was "Scheisse, Johnny." Shit, Johnny. All the time. Shit, Johnny. Shit, Johnny. Shit, Johnny. He was a mean German. He was a good coach. But today we have one of the nicest Germans I've ever met. Nicest person I've ever met. Dr.
Hey,
Alex, dude, every time I'm hanging with Alex, I'm full of like sunshine. He's like the nicest, happiest person in the world. We have
definitely got that vibe already. So that's cool.
Yeah, he's awesome, man. So we have Dr. Alex Franz on. He's a good friend of mine. Now you guys are getting to meet. We just hung out in France, in Lyon this summer, which was amazing. He's better than I am, man, because we went to dinner, maybe had quite a few drinks, and we're all leaving, and Alex is like, "Come on, we're going to the club." And it was like 11. It was an hour past my bedtime, so I just stumbled home and went out. So, did you guys end up going to the club, Alex, that night?
It was a good night.
Oh yeah, look at you, man.
The beer is good in France.
Yeah, I had way too many. But Alex, I'm just going to go straight into his bio. So Alex Franz is an orthopedic surgeon and a sports scientist from the University Hospital of Bonn in Germany. His research fields include peri, and postoperative muscle preservation in the clinical setting, as well as molecular biological mechanisms of hypertrophy and atrophy development. Furthermore, Mr. Franz is intensely researching the underlying mechanisms of blood flow restriction training and its applicability, effects, and safety in professional sports and patient populations. So this freaking guy, not only, is he like, I'm just like churning out all this badass BFR research, on the side, he's just like, I'm an orthopedic surgeon as well. So that's a 1-2 punch. So Alex,
and then everybody is shocked.
We're just shrinking back into our holes now.
Yeah,
Alex.
I know. What the hell have we done, man? So, Alex, welcome,
you,
man.
Yeah, thank you very much for the invitation. It's an honor for me to be here. And, and Scheisse, Johnny.
Scheisse, Johnny. That needs to be our new intro to the podcast.
We'll sell T-shirts that just say "Scheisse, Johnny" on it.
we have to make this beep now.
Yeah,
Scheisse, Johnny, like beep, Johnny.
Yeah, we're gonna lose our clean podcast rating.
I think we already lost that.
Yeah, right. Long time ago.
Yeah.
So, Alex, take us through kind of your background, what got you into orthopedics, and then what got you as an orthopedic surgeon to start studying blood flow restriction.
Yeah, my tour starts in 2011. After my school education, I started to do sports science at the German Sport University Cologne. And during my bachelor study, I was meeting a guy, Professor Behringer, and he introduced me to the sports science research. And it was not really a plan to be a researcher sometime, but it was so much fun. And so I started to do some, first studies, just small ones. And after my bachelor, he said, okay, now you have done sports science, and this was quite fun, but now you have to do something serious, especially if you want to be, a big one in the research society, especially if you want to be the first one on the paper or the last one, or especially if you want to work with patient populations. And so I decided to do also this medical part. And 7 years later, I'm now working as a doctor here at the University Hospital in Bonn. And I'm very happy to have done a lot of research about blood flow restriction, about the effect on skeletal muscle, especially skeletal muscle hypertrophy, because a lot of my patients are receiving a lot of muscle atrophy because of their illness or during our hospitalized time. And so hopefully we can increase their muscle health sometime by using the right techniques. That's the goal later in life.
And it's awesome too. So you have a sports science background, and some of your work is even looked at that. We're going to talk about IPC for eccentric contractions, but it's also cool because your focus is primarily on total joints, right? As a surgeon.
Yes, because it's one of the most standardized operations in the orthopedics. If you see the ACLs, for example, as well, but I think that especially the patient population which is receiving a total joint, like total hip, total knee, we can have a lot of impact on these patients if we use the right techniques pre or post-operatively, because of course ACL rehab is we can increase it and we can modify it, but it's normally they are quite fit guys or fit females which is getting an ACL but the thing is with if you see your mother, if you see your grandmother, which is receiving a total joint because of pain, and you know how the muscle atrophy is working over years. And so I thought we can do more good to these kind of patients if we do good research on them to prepare muscle and also to preserve muscle during the hospitalized state. So
we spoke at the Bologna conference together virtually, but it was, you did a slide on there when you were talking about total joints, which I thought was really interesting, where you stated it's one of the most standardized and most successful surgeries, but the outcomes aren't really as great as we think they might be. They're good, but then you cited quite a bit of data with preoperatively how poor the muscle is postoperatively.
Yeah, it was quite interesting because I think in 2015, I was talking to my former chief, Professor Zilkens, about how we can improve the clinical outcomes after total joint, because the implants are highly standardized. The whole operative procedure, it's like 45 minutes for a knee, sometimes 30 minutes for a hip. You cannot be faster anymore. Then also the rehabilitation protocol here in Germany is quite standardized. It's really highly effective, hopefully. Mm-hmm. And if you look on the length of hospital stay, if you look on the pain afterwards, everything is good. But if you go deeper into the details on skeletal muscle, you see that the muscle atrophy, which is already evident before the surgery, it's also evident afterwards. And there was one study which showed that 3 years after a total knee joint, you have still a significant reduced muscle mass 3 years after your total joint, and your contralateral leg is also significantly reduced in muscle mass and strength. And I was a little bit shocked about that, because we say, okay, that's the gold standard if you have an arthrosis, an osteoarthritis of the knee or of the hip. And if you look 3 years later, we have improved the pain perception, yes, but the whole rest, the skeletal muscle, is still in a bad condition. And I thought, okay, this could not be the gold standard, or you cannot pronounce it like that.
Yeah, it's fascinating. And I love your perspective from coming at this, of looking at not only is it, post-surgical that, you start to see these things happen, but these patients are coming in like this already at times as well. Decreased quad strength, decreased muscle mass. And so, your clinical research kind of spectrum is you're looking at things from a prehab perspective. Is there something you can also do perioperatively to maybe, fight against the insult of the tourniquet and the surgery, and then post-operatively? And so that's a beautiful spectrum. And I'd like to get into, because you wrote a really great hypothesis paper on ischemic preconditioning. I'm tooting your horn here, brother, on ischemic preconditioning and how it might limit muscle damage. And specifically a sports science side kind of thing of, eccentric muscle damage, but then also that the eccentric muscle damage that we see from contractions is similar to ischemic reperfusion injury. So if you can kind of touch base on eccentric muscle damage and how it is similar to ischemic reperfusion injuries, even telling our listeners what ischemic reperfusion injuries are, and then kind of let's lead into, after you talk about that the paper that you did looking at IPC with eccentrics.
The basic idea to that point was we see muscle damage, of course, after eccentric exercise, and we see also muscle damage after total joint if we use tourniquets, for example, during the surgery. And so we thought, okay, maybe there are some ways which are maybe the same if we look on muscle damage. And yeah, if you look deeper into the physiology of the muscle, you see that, of course, the induction of the muscle damage is maybe different, because on the one hand we have a mechanical part which is increasing the stiffness of the muscle, and then also some muscle cells are getting damaged. And on the other hand, we have first an ischemic part, which is more a metabolic advantage for the muscle, metabolic stress, which is then resulting into an energy supply problem, and which introducing a muscle cell swelling, and afterwards we have also kind of a damage. But if you look further, after this induction of stress, you see that the inflammatory response is quite the same, because the body has not the opinion to say like, okay, I'm doing a specificalized inflammatory response here, and on ischemic in context of reperfusion, I'm doing something different, because the body is working in the same manner all the time. And so we thought, okay, maybe the induction is different, but the sequence which is coming afterwards is quite the same. And so we thought, okay, what is possible, and how we can reduce muscle damage on the one side or on the other one. And we thought, okay, of course we can prepare the muscle, because we see it in context of muscle preparation on exercises, on eccentric exercises. That if you're doing exercises before, or if you're doing the same kind of stress before, the muscle is reacting in a total different manner. And we thought, okay, maybe we can prepare the muscle on context of this ischemic preconditioning if we're using an ischemic preconditioning like effect. And of course, we are not able to do like ischemic all the time to the legs of our patients. This is not possible. And then I came in touch with the blood flow restriction exercise, or with the blood flow restriction idea, and thought, okay, we have a patient which is not able to lift high loads because of the pain, which is not really able to do another kind of hypertrophy training, and he is kind of close to an ischemic reperfusion injury or stress which is coming up to his leg if he's getting into the surgery. And so we thought, okay, maybe we can bring this together to introduce them to an exercise stimulus which is nearly close to the stress which is coming during the surgery, and of course able to improve muscle mass right before the surgery. And so we looked a little bit into the molecular mechanisms and said, okay, maybe we can prepare the muscle, for example, in context of metabolic adaptations. If we get the muscle used to ischemic stress or metabolic stress through blood flow restriction, maybe he's able to correspond in a better way during the surgery. Maybe we can also modify the inflammatory response during the surgery if the muscle and also the whole body is getting used to this kind of stress. And we tried it and it worked actually. Of course, there are two reasons why it should work. Of course, if we prepare the muscle in front of a surgery, in context of like a better in, better out effect, the patient has more muscle strength, no more muscle mass. And we know that if you're getting more prepared in such a surgery, you will increase or recover faster afterwards. But all pre-op studies before didn't show this kind of result. They showed all that we were able to improve preoperative value or preoperative mass and strength, but not the postoperative one. And blood flow restriction was the first prehabilitation technique which was able to increase pre and post, and significantly pre and post. So I think that we were able to induce some kind of resistance effects into the skeletal muscle tissue, which then enables the muscle to respond better to this ischemic preconditioning, this ischemia and hyperfusion injury, hopefully.
So looking at the actual study where you did bicep curls with IPC. So just so we can understand the protocol, it was 80% 1 rep max eccentric bicep curls, right?
Yeah. One funny story. I have done this study with Ken Nosaka from Australia. He's I think the most famous guy in eccentric exercises. And I was coming from Perth, from his lab, coming back to Germany, starting doing this medical study, and all my friends putting them together. Come on, let's do a study with biceps curls. It's getting fun. And we were looking on the protocol, and the first protocol was 110% of the 1 rep max, 6 sets with 10 repetitions.
Jesus. You took your arm out for 3 weeks.
So it was proved by not only me, it was Professor Behringer, Professor Nosaka, and also the ethical committee. We said, this is a quite good idea. And we said, okay, we know from studies from ischemic preconditioning that we can reduce ischemia reperfusion injury. And I just wanted to have a look on, okay, maybe it's also working in muscle, in eccentric exercises, because if I postulate that it's the same kind of process, if the damage is induced, so maybe it has also an impact on eccentric exercise. And we did this kind of protocol, and we had some not so brilliant results afterwards. There's also a study out with where Jan Frieder Hamsen is the first author about muscle damage. We had CK values about 86,000 units per liter. The guys,
everybody's pissing brown.
Yes, we had some serial problems afterwards because the guys are coming in were not able to extend the arm totally afterwards. And a measurement 10 days afterwards showed that we damaged so much muscle that we lost 2 centimeters of circumference of the upper arm. So we actually we damaged muscle totally.
Wow.
But the good thing was, okay, ischemic preconditioning is not working if the stimulus is too high.
Yeah. Okay.
So
well, I think we'll make sure no one does 110 of their 1 rep max for 6 sets. That's understandable.
The interesting thing is, after these sets, on the exercise day, everybody was totally happy. And we think like, okay, maybe the stimulus was not high enough because nobody has kind of pain. Everybody was quite happy, like, oh, it was hard, but totally fine. And on the next day, everybody was totally damaged.
Checking into the ER with their CK values. Okay, so you took it down to 80% of the 1 hour.
So we modified it, and we did with I think 80% of the 1 rep max. And then 3 times. It was enough because we saw the effect that we hypothesized. We saw that by using
just a step back though, you did IPC 3 rounds for 5 minutes, the typical kind of IPC protocol before the eccentric exercise.
Yeah, directly.
So you had the controls were doing heavy, no IPC or a sham, and then the IPC group got IPC at basically 100% occlusion.
Yep.
Yeah.
And actually it worked. So we were able to significantly reduce the muscle damage afterwards, also the pain and also the muscle swelling afterwards. And this was a hint for me to say, okay, if this technique is working in the clinical part, the ischemic preconditioning and the eccentric exercises here, maybe we can put these worlds together. Because in my opinion, a lot of research findings from the sports scientific world could be help the medical world to improve the care of patients. But I see it a lot of times that these worlds of the medical area and the sports scientific area are not really connected to each other and not talk to each other. Yeah. And we want here in Bonn, we want to change that. It's quite simple, just to bring the techniques from the sports scientific world in our hospital, in our surgical room. And I think that we are able to improve the therapy of our patient with that.
Yeah, and this is, Stephen showed this twice. Stephen Patterson, our friend, who was also with us in France, he has 2 papers now that show this reduction in muscle damage and improved strength and improved VAS. Your CK values were significantly lower. At basically like every time point. So you had baseline, you had 24, 48, 72 hours later, and blood draws looking at muscle damage were significantly down. And this has been shown by, I'm blanking on the other guy in England, Kyle, that did the sprint one. But that, multiple papers now have shown this IPC protocol really blunts the creatine kinase as well as these indirect markers, which is fantastic.
Yeah. But what we have but what we have to look now is how the effect of the hypertrophy training is maybe reduced by ischemic preconditioning. Because we know from cold water immersion studies, for example, that it's also reducing the acute muscle damage, but it also reduces the response or the effects of the hypertrophy training later on.
Right.
So in cold water immersion, we have not these kinds of enhancements in muscle strength and mass after a 6-week or 8-week protocol, and because of the reduction of the inflammatory response. And I think that by ischemic preconditioning, we're doing quite the same. We are modifying the inflammatory response, and it's getting not too endogenous heavy. But the problem is maybe we need kind of these mechanisms to reach our goal. Muscle mass and strength.
And I think it's from a sports science perspective, this wouldn't be a training kind of technique. It would be more of a in-season game technique, Okay, if I have less muscle damage because we did this prior to a game, who cares about the hypertrophy response at that point? It's just I need to get my strength back quicker. But the rest of the time you're doing everything you can to just maybe induce some of that muscle damage in the build up to the season, right?
I know one funny response from a team coach in alpine skiing in Germany, because he also practiced ischemic preconditioning before the tournament, and they are sitting all with their contractants in one room, and these guys are putting these tourniquets around, and the coach said it's okay if it's not working, but the other guys are looking so strange to us, so there is a psychological effect.
Yeah, all right, for sure.
All right, whatever.
100%. I was going to chime in. I think the other kind of piece that we didn't quite touch on yet is we really don't know metabolically in the muscle what's happening during, say, resistance exercise or aerobic exercise with BFR versus IPC, and are they kind of really ultimately creating a similar environment? And does that repeated exposure to BFR exercise really kind of elicit the same effect as IPC at some level, and modifying that inflammatory response and that sort of thing? So I feel like there's that kind of that other layer there, and you guys touched on that a little bit in that invasive catheterization study, Dr. Franz, where you were talking kind of clinically the muscle looks a certain way, these ion bases have changed, and maybe we're able to kind of manipulate those. through?
You're totally right, Carl. I had a little bit the problem by a lot of this research that we see just indirect markers of what's happening to the muscle and what's happening to the body. And so we thought, okay, how we can improve maybe the outcome of our hypothesis. And so we started to do a little crazy study actually, because we took 10 healthy sports scientists or sports scientist students and used intravascular actually
plus one orthopedic surgeon.
Orthopedic surgeon, yeah. And yeah, we did intravascular measurements of the exercising arm. So we did an arterial catheter in the arteria brachialis, and also a venous catheter in the venoso-dorsale manus on the back of the hand. And so we were able to measure the blood pressure inside the arterial system and inside the venous system, really located in the exercising arm, not indirectly by using tourniquets or something, but really in the vessel. And of course, we were able to measure blood gas analysis and also muscle damage markers directly in the arm. And yeah, the results were absolutely amazing. So we did basically protocol 30, the 4-set protocol, 30 repetitions in the first set, and then 3 times 15. We did a crossover study. So all the guys are coming twice to overlap. In the first row, randomized with or without blood flow restriction, and then 30% of the 1 repetition max unilateral biceps curls. And yeah, the first thing that we saw is that no subject was able to lift all 75 reps with BFR. It was not possible for them. We had this kind of 30-second rest in between the sets. It was enough for us to took the blood gas analysis. And if we look on the results afterwards, there was it shows why it was not possible, because we see lactate responses from 8 millimole per liter in the BFR group in comparison to about 2 or 3 sometimes. And I know that the highest score was 18 millimoles of lactate in the exercising arm, if you look in the venous part. And of course, this is a huge metabolic response, which is actually bad.
It's crazy.
Yeah, this is totally crazy. And but it shows a little bit that if we're using blood flow restriction, we are playing with the physiology. And this is one of the biggest things that I would like that everybody which is using blood flow restriction has to understand, that if you're using this technique, you are changing the normal physiological working mechanisms in the body, because this kind of stress the body knows just in pathological conditions. This is not a normal stress which happens sometimes and we can use it. If you use blood flow restriction, you're changing the metabolic working mechanisms, and you have to understand that you're playing with the physiology. And this is especially important if you start working with, for example, cardiovascular affected patients or something, because something can happen because you try to modify everything there. And if you look on these lactate responses, this is absolutely huge.
Yeah, it's great. Yeah, almost like a trauma type situation.
If you come with this value into my emergency room, you will be in our clinic, hospitalized, and you get a lot of fluid.
Yeah, yeah. Luckily, when you had the reperfusion from cuff deflation, did you deflate and see how quickly that response went down?
We just looked 5 minutes afterwards, and we saw that the results are quite normal then. Okay. And also the sodium and the potassium levels are changed to baseline in 5 minutes, which is okay. But we thought, okay, what's happening if we're working, for example, with a cardiovascular affected patient? No, it's like a heart insufficiency or coronary heart disease or something like this. You're working both legs, blood flow restriction, a lot of muscle is working there. You are inducing a high metabolic demanding situation. You have a lot of lactate, you have a lot of potassium and sodium, which is going outside of the muscle into the vessel system, and then you open the cuff, and everything is running in the systemic condition. And of course, the heart can be affected by that.
Yeah.
Once, if you decrease both legs to the same time, because so much blood volume is coming back to the heart, that this could be a problem first, and then the ionic situation as well. And so if you work with patients, or if you work with affected subjects, you have to think about, okay, what will I do, what I'm doing there, and you have to understand that you're playing with the physiology. This is, for me, a really important part. Maybe this is also because of the medical point of view.
Yeah, no, you're seeing people with multiple comorbidities, and I don't think a lot of people think about what the effect of that reperfusion is with such a high metabolic load. And then also, I mean, on your point, people are like, well, I want bilateral. And if you're looking at a clinical patient, unilateral is probably more than enough for this person. If you want to do the other leg, switch over. But, from your work, you're putting a really high demand on them when you're doing both limbs.
Yeah, you're absolutely right. And an interesting thing is we already finished the study now, where we did the same thing again. We thought we found 10 new guys which were interested to do this crazy stuff. And we did it again because some of the reviewers responded to our study like, okay, you are not comparing the same kind of exercises, because of course we were not able to finish 75 repetitions if we use BFR, but 75 repetitions without BFR was quite easy. Mm-hmm. So the comparison was maybe not the best. And so we thought, okay, then we will do another round where we compare low load BFR and high load exercise. 4 sets all out during every set, 1 minute of rest in between. And then let's look how the muscle or how the body is reacting if we try to make a fatigue protocol there.
So effort match, basically. Yeah. Like everybody's kind of going to the same effort level. Yeah.
It was also crossed over, so a crossed over design. So we were able to, three times a theoreticus. It was a pleasure.
Did you space them out 4 weeks like you did in this also?
So 4 to 6 weeks.
Yeah, so that takes a while just to get
because
3 sessions.
The artery has to recover after that. It's quite funny that the ethical committee said yes to this study. But we did it again. I'm writing actually the paper now, nice. And we see the same results actually. If you look on the metabolic demand, and also, of course, the workload is quite different. You compare the load. If you make sets, multiplies with the weight, and doing other repetitions, you see significant differences. That the BFR trial has significantly lower amount of work in comparison to low intensity and high intensity. This was quite even actually. I know that my first set with the biceps curls in the all out condition was 93 repetitions.
Wow.
Nice.
Until I was so exhausted that I was not able to lift it again. So there was 90. I think the record was 107 or something like this.
Wow.
It's funny because if you're doing 2 seconds concentric, 2 seconds eccentric, you are doing 5 to 6 minutes just one unilateral biceps curl.
Yeah. Jesus.
But if you look later on the metabolic responses, it's quite even. So we see the same amount of lactate, we see the same amount of rising in sodium and potassium, we see the same rise in partial pressure of oxygen and CO2. It was really quite the same. So if we really start doing exercise till muscular fatigue, which is able to induce hypertrophy effects, it's totally equal what you're doing, because if you're using high intensity, low intensity till fatigue or blood flow restriction, the physiological response at the end measured in the exercising arm is the same.
Yeah, just much lower workload. BFR just gets you there quicker.
Yeah, it's really I think it's the first time that you see the physiological responses are the same, and BFR, as you said, Johnny, it's just a quicker way. To go there.
You also looked at, I don't even know if you would call it a hemodynamic response, I guess, but what the blood pressure response is within the artery as well. What do you see?
You see, also in low intensity, of course, the blood pressure is not rising that high. But if you compare the blood flow restriction and the high intensity exercises, you are quite the same. We measured not every exercise or not every repetition. We measured every 10 seconds, and then we'll do the the median of that. And it was quite the same, actually. But what is, of course, interesting is if you look at the venous part, if you look on the venous hypertension, because as we measured before in the first study, we saw an increase of the pressure of the venous pressure about 80 millimeters mmHg. And if you look on the standing person, you have a pressure of about 30 in the hanging arm and a pressure about 80 at the ankle, if you're in a standing position. If you're doing now, for example, quads and standing position, doing quads with blood flow restriction, you rise this pressure of 80 in the venous system at the ankle of about 160 to 200. So you have a huge hypertension in the venous system, which of course can have some effects later on the venous function. And so we also did a study, which is also now finished, about the effects if you're using unilateral leg extension exercise.
Those pictures look miserable. I send me that power. You guys look like
you saw the pictures?
Yeah, you sent me some pictures with the catheters in between your toes and trying to do leg extensions with BFR.
So we said, okay, we do not need an arterial catheter there, but we put a venous catheter at the back of the foot to also have measurements here right in the exercising extremity. And yeah, we did some venous functional parameters of venous functional tests before and after. This is called phlebodynamometry. Actually, you're doing heel raises, and in a normal physiological condition of the venous system, you see a decrease in the pressure because the muscle is working and is pressuring the blood upwards.
Mm-hmm.
And so the pressure in the venous system is going down. And if you stop doing exercise, the pressure is rising again because it's getting fulfilled. The venous system is filled back. This is the normal condition, and we measured it now before and after these kind of exercises, and we saw actually in young, healthy patients, no effects. So for a young population, which is normally healthy, we see that we have no acute bad effects on the venous system if you're using blood flow exercise. We did this because we want now to upgrade this research on specific patient populations and also on venous affected patients, because if you have a venous valve dysfunction, for example, maybe blood flow restriction is not the best way for you to do exercise because it can maybe enhance the problem. Or maybe if the venous system is not so young anymore, maybe it's getting also affected by this. So therefore, we did this now in the first study, which young guys, this is quite fine. And now we will increase this idea to different ages and different populations.
Okay, interesting. So
can I tell you a funny venous story? Has a little bit of color here. So we had this patient years back in our clinic, and he comes over to me out of nowhere, and he was like, "Hey, Jennifer, she said I needed to come tell you about what happened to my leg." And I'm like, "Okay." And he was like, "You see how I got like these little spider veins, these varicosities on this one leg?" And I was like, "Yeah." He goes, "Well, I used to have them over on this other leg, but we've been doing BFR on that leg and they went away." And I went, "That's interesting." And he was like, and I was like, "Man, I don't know what really to say about that. I don't have any kind of conjecture. It's not something I've heard." I said, "But the one thing I do need you to do is, as you leave, just like stop by the front desk because there's an extra charge for that."
Yes,
he thought I was so serious. He was like, "Oh, you suck." But yeah, those are funny. And I don't know. I mean, it doesn't really make a whole lot of sense why that would happen, but at least I can't come up with a reason. But
actually, we don't know what's happening in the muscle. Actually,
yeah.
so this is But it's a good story. I have to tell this to my patients. Maybe they are then
There you
more
go.
Maybe they'll buy in.
Yeah.
Get rid of their varicosities.
There you go.
Well, you at your institution, you guys have adopted BFR in your total joints very early. Am I right on that? Yeah. And is there, knowing that it seems safe on the venous system and younger, we're not sure, and older, do you have any safety concerns? We get a lot of questions like, when can I start this with a total joint? So what are your thoughts and how you guys have instituted it?
So we have now prepared 2 studies in the University Hospital of Bonn, and one of them is in total joints, where we use it post-operatively. For example, we start at day one after surgery. We put the tourniquet around, doing pressure of 80%, and have a look on the muscle atrophy afterwards, because we want to reduce it. Actually, the only thing which is uncomfortable for the patients is the LOP measurement before. The 80% of pressure we're doing in interval training, like we're training both legs, because we know that during hospitalization, both legs will lose muscle mass. So we want to train both legs, and during the exercise, we're doing 5 minutes per leg, and then 6 times in unilaterally interval times. We see no problems, and the comfort of the patient is quite good. Interestingly, I saw one patient which was using blood flow restriction during their range of motion training, because she said that if she start training the flexion, it hurts. Said, okay, it was day 3 after surgery. Of course, it can hurt. And then she started doing it by using the pressure. She said, and now I feel no pain anymore. And she was doing a flexion till 90 degrees. And before it was like 30.
Wow.
So not just because of to prepare the muscle or to maintain muscle mass, maybe it's also good to train in total joints the mobility afterwards, because I don't know what's happening, because we know about these hypoagesia effects, which is BFR inducing, but it works. And a lot of patients now, which has problems by using by the range of motion therapy through our physiotherapists, are now using blood flow restriction to improve the range of motion therapy.
Yeah, we've had the same anecdote, and actually they have a study, and I think it's going to maybe show this as well. Range wasn't one of their primary outcomes, but with ACLs at Memorial Hermann here in Houston, same thing.
Yeah.
That when they were working on range, if they did it with the tourniquet on, it seemed to help them get there easier.
Yeah, I don't know how this can happen in such an acute manner, because of course it modifies something, but modifications on spine level take some time, and it's not working directly in the moment. But it's really successful.
Starting at day 1 post-op is pretty incredible. Now I should have sent my mother-in-law. She had a total knee this year out there to Germany, so y'all could do it on her, because she was bitching 2 weeks post-op when I was trying to get her to start it. So, our biggest question really is tolerance, and it sounds like everyone's tolerating it pretty well in your study. But the big one too is the incision. A lot of docs are really nervous about the incision with the total joint. Always tell them actually what should happen. Yeah, really, because think about it. If you look on the wound healing, what should happen if you use 5 minutes of venous block? Because if you're doing the surgery and you closed the wound, and if you have closed it in a good manner, so what should happen if you use a venous block? I discussed that with my chief, because he also said, okay, well, to which time point do you want to start? And I said, yeah, Dave, I would like to start during the surgical day. This was my initially idea. And he said like, no, then I have pain, and maybe what is about day 3 or 4? I said, okay, now then day 1. And we discussed that and said like, okay, what should happen? We know that this thromboembolism idea is not there, because we see so many meta-analyses and we see so many clinical studies now, which is showing that there's no adverse effects on that.
There's more this fibrinolytic effect, which is working. Pain reduction, we know that it's an hypoalgesia effect. Maybe we can reduce the amount of painkillers which they are using, of opioid use, for example. Wound healing, we know that these metabolic phases of venous occlusion, energy supplies changing, is helping bone tissue, is helping wound tissue to heal, because the functional hyperemia, which then is coming, maybe is more promoting wound healing actually. And if you have done the close of the wound in a good manner, what should happen actually? If you have done a bad closure, then you have a problem, but then you have a serious problem to all situations. But what should happen? And so we decide, okay, let's do it.
And no issues at all.
no issues, nothing.
All right, Kyle. So when someone says their doctor won't let them do it post total joint, we'll just say, well, ask your doctor if they're a crappy at doing their suture techniques.
But give me a really good a good reason why I should not do this. And I thought about it, and we discussed that in our clinic with our chief. We looked at the literature, and we didn't find one reason which is really evident enough to say, okay, we cannot do it.
I think they always just fall back on, well, two things. One is, well, the swelling might put some stress on the incision, but again, it's like, there's swelling already. It's not going to change that much. And then the dumb comment typically is, oh, hypoxia. It's gonna, the wound's not gonna heal because of hypoxia, because you got 5 minutes of subocclusive artery.
And afterwards, and if
you get an angiogenic.
The funny thing is, if you look on the arterial part and the venous part of the vascular system, and you're using blood flow restriction, you're seeing enhancements in the hemoglobin content in the arterial part.
Right.
And also the oxygen saturation is rising in the arterial part, because the muscle is getting affected, it's getting trained by this metabolic stimulus. Of course, you have a venous blockage, so the oxygen is not coming into the capillary system because it's blocked there. It's blocked back into the arterial ones. But in that time, if you remove the cuff, you have more oxygen which is coming there. And we know that we have some effects on the hormonal effects, that on vascular endothelial growth factor, for example. So whatever damage to the soft tissue we did in the surgery, I think that by using blood flow restriction, we enhance the repair mechanisms afterwards. I don't think that we negatively affect them. I think we positively affect them, because we know that the body then is reacting in the good manner. This is my opinion.
Yeah.
And
I mean, it makes sense.
You have a trial that is looking at post-op right now, day one?
Yeah.
You do?
Yeah.
Okay.
Yeah, one with total knees, and another one in spine surgery after spondylolisthesis. The idea is, on the one hand, they have spine surgery patients also receive a lot of muscle loss after surgery, because they are quite the mobility is reduced during the first 7 to 10 days if everything is working normally. And so we wanted to have a look what is happening on the wound, because in total knee we have the wound distal of the cuff, and in spine surgery we have the wound proximal of the cuff. So we can have a look, okay, what is happening there, and can we increase the effects, or do we have an adverse effect on the wound healing? I hypothesize there's nothing happens. Maybe it's getting better, but so we want to check this. We are now a little bit in a discussion how we can do it in total hips, because you have to decide which approach we are doing. We are doing the anterolateral one, and if you're using the cuff there, you can affect the wound, and this, of course, is going to induce pain, and then the compliance of the patient to the technique is reduced. So we are thinking to using blood flow restriction on the contralateral leg to increase the stimulus there a little bit, or to train at the first day the contralateral one. But we are in a discussion about that.
Yeah. Well, the contralateral leg gets ignored anyway, so get any stimulus on there, and we, there is a possible crossover effect. To the other limb, as long as they use.
And this is such a good example for that, because from sports scientific point of view, we know that there is a contralateral effect, there is a crossover. And if you say this into a conference of medical doctors, they said like, what's that? And this is one of the biggest things where the medical area can learn from the sports scientific ones, because we know you do not have to train the extremity which is injured. You can also train the contralateral one. You can also train the arms if you want.
Yeah.
But you can induce helpful effects if you train something in the body which has not been the injured leg. And in the morning we had a big. Every morning we all sitting together looking at the day, what is happening in the surgical room, how many people are there, and then we have like a small discussion, a small presentation of one of our doctors, and one was doing a presentation about healthy food in the hospital, and of course our food is not healthy in the hospital.
Yeah.
And I think in all hospitals in the world the food is not healthy. And he presented a study about the effects of essential amino acids. If you putting them into the normal diet of a patient during the hospitalization, you can reduce the amount of muscle atrophy, and you can also reduce adverse effects from the surgical point of view, and also from their comorbidities. And again, it's just saying, if you look a little bit how the metabolism is working, and if you look a little bit how we can prepare and maintain skeletal muscle, you can increase the health of your patients, and you can reduce your post-operative complications.
And it's not hard to do.
No, it's not really hard to do.
The bar's so low at that point.
Yeah.
You know?
But
that's
then
the
big question in the afternoon, like, oh, your surgery was 30 minutes too long. I said, no, the problem is before and after. Of course, short times is good, but if you prepare it before and doing a good therapy afterwards, you can have a better effect than you can also doing a surgery 30 minutes longer.
Yeah. Well, it's kind of like ACLs, it's, looking where the graft placement is, if it's a millimeter over this way or that way, what's the difference? And then
but no muscle to move the joint.
and then they go back with a 70% quad. It's like, I don't think your graft even mattered at that point,
Yeah, exactly.
Totally. It's correct.
Exactly. I had a question, Dr. Franz, on the intervals that y'all are starting on day one. I'm assuming it's just basically inflate, deflate. You're not actually doing exercise. And then are you kind of progressing to some sort of BFR exercise at some point, or? Yeah,
during this study, we are just using the blood flow restriction stimulus, because I wanted to know, what is happening if we're just using this ischemic hypoxia and reperfusion effects, but we want to improve to modify the protocol, I think in January or February next year, to include also electrical stimulation afterwards.
Beautiful.
In my opinion, to do good research, you have to set one stimulus after the next. So the first stimulus.
I just am gonna be happy the rest of the day for you saying that. Not like 18 different freaking outcomes,
Yes.
The problem is if you're doing a study where you took electrical stimulation, eccentric exercise, blood flow restriction, and a beautiful woman which is working behind you, you have a lot of effects. Yeah,
exactly.
But we want, but if we want to really do good research, we have first to think about, what is happening to my patient, to the clinical outcome if we just use metabolic stimulus? That's the first question. And after this, if we know, what's happening there, and we are doing a normal intervention and a control group is a sham BFR exercise because we want to reduce the bias, of course. And then the next step is to implement also electrical stimulation, because then I have also to build up a group which just received electrical stimulation to see the effects over here. So in my opinion, you have to do small steps to get the right decision and the right opinion afterwards. And
got to lay the foundation to build.
Appreciate that you like this idea, Kyle.
Yeah. I do. I really do. Yeah.
Well, and also I like your approach, Alex, where you put out a paper explaining your hypothesis. That seems to be your style. And you know, from prehab to, IPC for eccentrics, and you kind of lay out, this is our thought. You don't kind of keep this a secret. And then the next one is like, okay, we're going to go see if this works or not. And you do the study. And I always think that's a great, and then you can also cite yourself in your second paper, which is my.
Yes, of course. This was a really good thing.
Donnie loves the self-citation.
I'm a
Yeah, as a young scientist, it's quite cool to say, okay, it was done by Franz et al.
Yeah.
But I got one reviewer who said like, okay, there are also other studies. But they're not good. No, fun.
That's awesome.
No, but I think if we want to do good research, we have to discuss with all researchers in the world, and so it's not helpful if I don't show my bad results, my good results, or my ideas. And of course, everybody can have another opinion to say like, okay, Dr. Franz, you're telling totally shit. This is totally fine, but then just come here, discuss it with me, and tell me why.
Right.
And everything is okay. And so everybody who has questions is free to ask me, is free to call me, because therefore we are scientists, actually.
Yeah. Let's roll into your prehab study a little bit deeper that just published this summer in Frontiers. So 6 weeks, twice a week, blood flow restriction cycling in total knee patients, or doing the same exercises without, or a control group that just did nothing, which you called standard of care, which is basically the standard of care in the US as well, do nothing.
In Germany as well.
Yeah. So can you go into that study? Because it's got long. So a couple things. It's very clinically easy from the way you did it to your measurements. It's not you got to have a highfalutin T3 MRI to do this sort of thing. And also you looked 6 months out. So we're seeing some long-term changes. So can you elaborate on that study?
This study arises by a discussion with my former chief, Professor Zilkens, which is doing a lot of endoprothesis on hip and knee. And he said, like, okay, I would like to increase the outcome rate. We said, okay, the surgical time is good. We have not a lot blood loss. The rehabilitation is good. Let's do a prehabilitation thing, and then let's do a study with that. And so we discussed, okay, if we have patients with agonophosis, what can we do? And every patient, and really I talked with a lot of them, every patient is able to do cycling exercise because they like it. It's not hurting so much. And if you're using the right intensity, everybody is able to do it. And so we said, okay, let's start slowly. Let's start with a cycling exercise by an individual intensity. It was measured by the heart rate reserve. And doing a small step test, and it was about 80 watts or something like this around, if you look through all patients. And then we said, okay, we're doing now blood flow restriction on it. And it was one of my first studies which I started, and I was a little bit, I wanted to be safe that all the patients are finishing the study. And so I started, okay, let's do just 40% of pressure, which a lot of other authors said, okay, this is too less. And I think Johnny also would say that you need more pressure if you want to have the good results.
If you can have lower, I'll take it.
And what we saw is that by using 40% of pressure, we see also significantly effects. If we looked on the lactate responses, for example, in front of the exercise and afterwards, and we saw a lactate of 6 systemically by using 80 watts, 50 minutes long. So it was not really heavy for the patients, but you saw a metabolic response. They did it twice a week, 15 minutes. We trained both legs, and we just using unilaterally blood restriction application. So first the left leg has done blood flow restriction, then a small rest, then the right one, and then we repeated this 3 times.
In their rest, they were still spinning for that 4 minutes.
Yes.
So 4 minutes right leg, 4 minutes rest, spin, 4 minutes left leg. You did that for 3 rounds, right?
3 rounds.
Sets.
Exactly.
Got it.
So it was quite simple. It was easy to do for the patients. We received no adverse effects on it. We have no patient which was not finishing the study. And it was quite simple to implement an active control group with sham BFR, which has just the tourniquets around by a pressure of 20, just that they're not falling down. And then we measure in front of the surgery, as in front of the prehabilitation phase, then after 3 weeks of prehabilitation, after 6 weeks, and then 3 months and 6 months after the surgery. We also measured the hospitalized time, the first 7 days, which I'm writing now the paper on, but the idea is a little bit different than on the muscle mass and muscle strength parameters, and so we decided to split these kind of ideas. And what we saw is normally, if you do prehabilitation without blood flow restriction, you see enhancements before the surgery, but you see the normal, typical course of muscle strength and muscle mass after surgery. So we have a decline, we have a rising muscle atrophy, we have problems in the neuromuscular activation, and so also problems by inducing muscle strength. And so we see the reductions afterwards. And if you look at our control group, for example, which received no prehabilitation at all, you saw these kind of curves. We saw reductions significantly in comparison to baseline. If you're using just the cycling ones, we saw also enhancements before the before surgery. We saw enhancements in muscle strength and also a little bit in muscle mass, but post-operatively we saw no changes at all. So the effect was okay, but this was not beneficial post-operatively. And then we looked at our blood flow restriction group, and it was massive because they improved their muscle strength about 120%, I guess. It was a 6 repetition maximum test on a unilateral leg extension exercise. So it was quite hard for them, and it was also painful for them, but it was 120% of the starting strength. We measured the circumference of the thigh to illustrate a little bit the muscle mass the muscle hypertrophy. Of course, it's not the best measurement tool, but using MRIs is quite expensive. You need to get the time slots for that. And if you're working on a university hospital, you have not the possibility to say, okay, this is my study MRI where I'm just doing my research on BFR. This is not possible. Yeah. We have discussed that with the reviewers before, because they said like, okay, it's not the gold standard. And I say that the clinical therapy is also not gold standard if you want to implement this into a university hospital manner. But we measured it, and we have an increase of about 5 centimeters in leg circumference in 6 weeks of exercise. Wow. And this was massive. And during the same time, we were able to reduce the pain of the patients to such a minimal level that the most often this discussion which I had with my patients was, why should I get this surgery now? Yeah. Because they started. So
you're not going to do this anymore as an orthopedic surgeon.
Really, I had to discuss that with them, because they thought that we have solved the problem, but this is not true. We did not solve the problem. We just maybe we were able to by using more muscle mass or improve the neuromuscular activity, that some parts of the joint are now more into the motion affected than before. So maybe we have changed a little bit the biomechanical parts of the gait. This is okay, because they are using more muscle mass, but we not solved the problem of the osteoarthritis. During this discussion, I said that we have now improved your muscle health, and so we can go into the surgery with an improved level of fitness, and so you can use this for your surgery afterwards, for your rehabilitation. So all the patients did the surgery, and we saw afterwards that this normal decline in muscle mass and muscle strength was not really evident in our blood flow restriction group. Actually, they were better than the baseline values pre-rehabilitation. So they improved their muscle mass and muscle strength, and improved that after surgery as well. So we were able to maintain these enhancements. And I think this is the first study which was able to show this. that not only the pain after TKA surgery was better, also the muscle mass and muscle strength.
And long term, that was 3 and 6 months, right?
Yeah, I would love to do the 12-month measurements, but because of COVID, it was not possible. So the ethical committee said no, it's not allowed to bring the patients into the hospitalized situation if they not have to come.
Okay.
So therefore, we do not have a 12-month measurement afterwards. But this was quite impressive because it was an endurance exercise with a kind of low load and low
pressure. Yeah.
So in my opinion, if you're using blood flow restriction in the patient population which has a reduced muscle status, you not need to get to these high pressures. Of course, if you're doing training with a sport guy which wants to run 1 second faster than before, of course you have to put pressure really high to get the metabolic impact. But if you have a patient which normally just walking around in their apartment and then is coming the first time to your exercise lab, you do not need so much pressure to have an effect.
That's an important piece.
Endurance. Yeah, and the endurance stuff, there just isn't really many pressure papers out there for us to know.
Right.
There's a lot more with the resistance training that we can kind of hang our hat on, but almost all these endurance ones where you didn't know the pressure or, it's just one pressure. So I think that's beautiful.
I think it's an important piece, Dr. Franz, too. I mean, because when you think about the data that we discussed earlier, on the arterial pressures and the venous pressures and in the metabolic environment that you're creating, those data were in a 30% load, a 50% pressure in trained individuals that went to failure, and this is a clinical population that we're talking about. Like you said, their floor is so much lower that the stimulus to create this adaptation is much lower. But that also means potentially, I would think at least, that the metabolic costs and those things that you saw in that catheterization paper are probably lower too, and potentially safer for these population that have these comorbidities that we are kind of concerned about. But we don't have to push them as hard as you got to push a trained individual. So I think that's pretty cool.
You do not have to if you want to improve the health of your patients. You do not have to put them into the highest intensity, whatever you want to do, but you do not need it. They will have success if they will start training and if they are able to train. And I think this is one of the biggest positive things of blood flow restriction because of the low load. It's the first time that a lot of patients are able to do exercise.
Do it. Yeah.
Exactly. Yeah.
And what's
Get
important
them going
again,
and progress it.
This is a good clinical paper because your self-reported, your COOS was improved, VAS was improved, and you had functional measures that were improved. Your 6-minute walk test, your sit to stand, which to the patients, these are what matter. How do I feel overall? And
totally correct, because this is what really matters afterwards. It's totally okay that they have more muscle mass and if they have more muscle strength. This is from a scientific part, this is totally brilliant. But in medical context, and then the medical world is coming, what really matters is that they have less pain and more functionality, more quality of life, because this is our goal.
Yeah. And again, that was the last
100%.
3 and 6 months, still better than that. Prehab, basically.
We are now doing another study with you, Johnny, as well. We discussed what we want to do. So now we try to do a resistance exercise study to see, which way is maybe the more beneficial one in total knee. Is the endurance one okay, or can we increase the effects by using resistance exercise? So we want a little bit to evaluate what is the best way.
Yeah. That's perfect. And again, stepwise, we love it. Get in that baseline.
It's the boring way, of course, and a lot of people think like, but this is more interesting. But if you really want to have a good story and you really want to explain what happens, you have to do small steps, in my opinion.
Amen.
Yeah, well, and if the resistance comes out better, great. But now you've set up a very easy protocol where you can say most patients can do this. They can ride a bike, and they can have unilateral BFR, at a lower pressure, you can get there. Maybe the resistance one, which Dr. Franz showed, can get you the next step, and you can throw that out to your patient. Let's try and see which one you can do. It's fantastic. If we can get the damn payers to pay for prehab.
Yeah.
Yeah.
I have to say, just anecdotally that, what you guys saw in this study, I experienced treating my patients, because I had, and it's like N of 2, but I had this experience with a patient where she came into me from her general practitioner, and her general practitioner had told her, go see Kyle, or these guys over there, and do some rehab. But, if it's not helping, then come back and we'll get you an MRI. Well, I mean, this woman had, a big extension deficit. Her knee was clearly arthritic, and the GP just didn't catch it, which it's whatever, And I said to her first visit, I'm like, look, I don't know that you really need an MRI. I think we can just kind of confirm some things with X-ray. And so she did that. She got to an orthopod, did that. But, I said to her, I was like, I'd really like to just do some prehab with you with this BFR thing, because we had already done a little bit, in the first visit, just sitting at the edge of the table doing a long arc quad. She's like, oh my God, I can feel my quad working. Like I haven't felt that. And I can't even tell you, it always hurts my knee. And I'm like, that's kind of the beauty here. And so we just kind of got lucky, and we were able to work with her, and her pain post-op, her range of motion post-op, those things were so much better than we typically kind of would expect to see coming in, and our ability to kind of progress her exercise post-operatively was better. That I just kind of got to that point where if I had a private payer that I could get them to do some prehab, I would be like, if you can give me like 4 weeks, 6 weeks, I think we can actually kind of really improve sort of those early outcomes and how you're feeling immediately post-op. And then we discharge you post-op faster than we might. And it seemed to work, but again, you're talking, this is my experience. It's like 2-3 patients, that you actually get to do that with, but
it's working. It's working really. If you start working with patients which has a problem on their legs, on their arms, also at the shoulder, for example, and you start using blood flow restriction training, it's massive. The effects, as I'm talking to a lot of other surgeons, and they said like, okay, I cannot imagine that something is working so fast, but it's working. And we do not understand what really happens there, but something big is then working if the muscle is trained well, or it's getting trained well. And all the doctors are quite shocked, because then they want to do it by themselves, and then they are smiling all the time. This BFR smile, if it's getting
BFR smile.
If it's getting and they feel like
resting BFR face.
I feel my legs. Then it's getting fun, and it's working. And one teaser I can show you, because
nice.
We're getting a little bit more deeper into the physiology of the muscle than invasive studies in the vessels. We are now doing a lot of research with intramuscular catheters. So during exercise, or maybe in front of the exercise, we put a small catheter into the vastus lateralis muscle. And we were able to get fluid samples from the muscle tissue. We can get out and analyze it. And now we are doing research with that. And we compared, for example, in the first trial now, the lactate concentrations at the ear, in the venous system, and measured in the muscle, intramuscularly. And we saw, this is totally insane. At the ear, it was about 2 millimole. In the arm, or in the working limb, it was about 4 to 6. And in the muscle, it was 31.
Wow.
So we want really to get into the muscle to see what happens there metabolically. Because if we can a little bit describe what happens there, we maybe have the chance to analyze the key mechanisms. What is really important if we want to train the muscle, if we want to interfere with atrophy, if we want to induce hypertrophy, what do we really need about this? And of course, in a sportific way, if you work with athletes, this is a total different story. But if you work with patients and if you're working as a doctor, if you work as physiotherapist, if you work with patients, you know that if we maybe are able to find which key we have to use to get the most beneficial effects, then we can really change a little bit in the medical system. And I don't think that in the next years or next decades, the biggest stories about post-operative enhancements are coming from the surgery itself or from the implant or something like this. It has to be to prepare the patients which are receiving surgery.
Mm-hmm.
Because we are so highly standardized in all the things which happens in the hospital that we forgot which patients receive this. And if someone is coming to our hospital which has done sportive activities, no sport activities since 10 years, it's not possible for them to have a really successful rehabilitation in a high quality of life manner. Of course, we will reduce the pain, of course, but we will not get them active into their home again. I don't think that this is possible by only the surgical or only the hospitalized phase.
Yeah.
So I think that the biggest chances to improve our health system and healthcare is to prepare the patients better.
That's awesome. The catheter study, which sounds badass. That's also one I thought we might have discussed a little bit in France, where proximal would be very interesting to see. What's going on at the glute or what's going on at the shoulder with a intramuscular catheter with this, because that's the big question where we just don't have a lot of answers as well.
Yeah. It's getting really interesting, because I thought it would be hurting if you have such a catheter inside your muscle and then doing exercise. And actually, it's totally okay. It's totally fine. And these catheters are handmade, and you can leave it in the body for 30 days if you want.
Wow.
No way.
So,
that's crazy.
Yeah, that's nuts.
So we start now to do some exercise research about it, but we also want to include it now into our hospitalized patients to see what happens in the muscle pre, peri, and post-operatively, to see what happens there. And in comparison, for example, to a muscle biopsy, which is showing you one specific time, we have the ability to really show how the muscle is reacting over time.
That's cool.
So it's getting deeper and deeper.
Becoming a ninja, man. That's awesome. Well, sweet, Alex.
Great Germans.
Yeah, so that's the German style. Very structured and always coming up with new technology. That's why y'all have the good
Scheiße, Johnny.
Yes. Scheiße, Kyle.
We bookended it beautifully. That was perfect. Scheiße, Johnny.
Well, this was with Dr. Alex Franz. Always awesome to talk with him. I didn't mention he's also editor for BFR specialty section for Frontiers in Physiology with our other buddy, Dr. Luke Hughes, and Professor Behringer. So got some all-stars on that, and going to be turning out a lot of cool BFR papers. And also, you do BFR certification courses for Owens Recovery Science over there in Germany.
Yep, in Germany. So if you want to get all the information in German, please come to Cologne.
Man, I know. I'd rather take a course from you than me.
No kidding.
Awesome, Alex. Well, I'm going to let you get some rest. Thanks for being on, and we will talk soon. Hopefully, we'll be in person in London in May. We'll see. Ischemic. Yeah. All right.
And then the ATSM next year.
Yeah.
I have to come to visit you crazy guys.
Absolutely.
I'm not going to any dance clubs. No nightclubs for me.
We'll see.
We'll see.
Cool. Thanks, Alex.
Yeah. Thank you very much.
Thank you. Thanks for coming. That was great.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.
One last thing before you get out of here. Quick moment just to say thanks for listening to the podcast. I think we've probably said it 2 or 3 different times now, but we really mean it. But we also want to make sure that you, when you listen to this podcast, that you understand it's not medical advice. We do our best to make sure the information that we give through this podcast is as accurate as it can be, but it should not be used to treat patients. Those decisions need to be made by a physician, by the appropriate rehab clinician, those people that are licensed to care for that individual in that particular state, nation, etc. And so this also goes for any guests that we bring on the podcast. They're not providing medical advice. This information that you have received here as entertainment should not be taken in that way at all. And it should neither be used as expert witness or testimony in any sort of legal proceedings. So thanks for listening to that and understanding that. And we will see you next time. Or wait, we're not going to see. We'll hear. No, we'll listen. You'll hear us. Yeah. Thanks. Okay.